Thank you, Dr. Bansi, for a very kind introduction. Good afternoon, everyone. At the outset, I must thank Manoj, Purvi, and Bansi, and of course, Team DRS for this opportunity. I am going to be speaking on recent guidelines and update on vitamin D in metabolic syndrome. Unfortunately, I'm not speaking on anything, in core obesity, which is my passion. And though this is our session, I'm going to speak on something different. And just for everybody's information, this is a sponsored session by LCAM. So this is my disclosure. So in this presentation, I'll briefly touch upon role of vitamin D in metabolic syndrome and also on the recent guidelines on vitamin D. There are multiple guidelines, but I'll be touching only on the Endocrine Society guidelines, which came last year, and the Indian consensus on, which is published in Indian Journal of Endocrinology on metabolism this year only. Now, we all know that vitamin D is an essential corticosteroid hormone involved in calcium homeostasis, bone mineralization, and has other functions also, including immune modulation and maintaining a normal metabolic health. Despite being widely sensitized through, sun exposure, the prevalence of vitamin D deficiency is widely prevalent globally, and India is particularly affected, though we feel we are living in a very sunny country, but we have very high prevalence of vitamin D deficiency and insufficiency. The past decade has witnessed the evolution in the understanding of its physiological role beyond the calcium homeostasis or bone mineral, maintenance, and there is increasing interest in its role beyond the skeletal benefits. Now, when we look at the vitamin D deficiency, usually it is subclinical, there are no symptoms, and that is why people don't notice it. Some people may have vague symptoms like bone pain, muscle weakness, frequent falls, especially in the elderly. But now we know that it may be associated with some of the chronic diseases like type 2 diabetes, cardiovascular diseases, and autoimmune disorders also. Now, let's have a look at vitamin D and metabolic syndrome. We all know metabolic syndrome is characterized by 3 out of the 5 components: central obesity, dyslipidemia characterized by high TG and low HDL, dysglycemia, and hypertension. If any 3 of these 5 are present, we label this as metabolic syndrome, and the relevance is that if there is clustering of risk factors, there is increased risk of cardiovascular disease. Now, we have evidence that vitamin D deficiency is linked to an increased risk of metabolic syndrome and, of course, with the increased cardiovascular risk. There are a number of studies which suggest that vitamin D may play a role in regulating these components of metabolic syndrome, and low vitamin D levels are closely linked with the increased risk of metabolic syndrome. In people with obesity, there is sequestration of vitamin D into the adipose tissue, and this leads to lower levels of vitamin D. In people with diabetes and obesity, there is increase in insulin resistance and decrease in beta cell function or compromised beta cell function, which is again, part of vitamin D deficiency, and we are seeing more link into these conditions. Low levels of vitamin D have been associated with higher blood pressure and abnormalities in the lipids also. If you look at the physiological function of vitamin D, I can use this pointer on screen. So you will see here in this diagram that vitamin D actually is associated with, anti-inflammatory state, maintains normal or lower inflammation in body by reducing the pro-inflammatory cytokines, reduce production of free radicals, decrease autoimmunity against beta cell, and improves endothelial function. It also improves HDL, lowers LDL, lowers TG, is associated with lower BMI, suppresses RAS activity, thereby lowering blood pressure, improves insulin sensitivity, improves A1C level, reduces insulin resistance, and also shows beneficial effects in long and short-term maternal complication in women with gestational diabetes. Now, vitamin D acts at multiple metabolic checkpoints, and the key areas which are associated with metabolic syndrome include pancreas, liver, adipose tissue, and muscle. And at all these levels, it improves insulin resistance, reduces inflammation, and improves fat distribution. It is associated with lower deposition of fat at the ectopic sites. Now, if you look at the pancreatic function, we have vitamin D receptors recognized in the beta cells, and we also have the enzyme 1-alpha hydroxylase. And presence of this enzyme actually produces local active vitamin D at beta cell level, enhances insulin secretion and insulin sensitivity, and reduces insulin resistance. Now, if you look at the inflammatory pathways, vitamin D level, the adequate vitamin D level is associated with increased production of anti-inflammatory molecule cytokines like IL-10 and lower secretion of pro-inflammatory cytokines like TNF6, TNF-alpha and interleukin-6. Also suppresses the RAS activity, thereby lowering blood pressure, also changes the adipogenesis and fat distribution by promoting fat deposition at the subcutaneous fat level and reducing the deposition of fat in liver, also reduces adipose tissue hypertrophy, thereby reducing the inflammation in the adipose tissue. Also modulates glucose transport level at the level of muscle by upregulating the glucose transporter 4 and increase uptake of glucose at muscle level and fat level, and protects against the endothelial dysfunction by increasing the activity of eNOS, which improves the production of endothelial nitric oxide and improves vasodilatation, vascular relaxation, and reduces the vascular inflammation. It also improves the lipid metabolism by regulating the hepatic lipid synthesis and clearance, and it helps in lowering triglyceride and improving HDL levels. The first evidence came from the studies based on the enhanced data of 1988 to 1994, when this population-based study, which was a cross-sectional analysis of 6,000 plus patients, showed that there was a relationship between the vitamin D levels and metabolic parameters like fasting glucose, 2 hours glucose, and serum insulin, and they found that there was a clear inverse association between vitamin D and increase the diabetes risk. Then we got a very interesting study called D2D, or study which was a study which looked at vitamin D supplementation and type 2 diabetes trial. So in this study, vitamin D supplementation was given to people with pre-diabetes, and study looked at whether we can prevent the progression of pre-diabetes to diabetes. 2,400 plus patients given 4,400 units of vitamin D on daily basis as supplementation, followed up for more than 2 years, 2.5 years. The levels of vitamin D significantly increased from 27 to 54, but no statistically significant reduction in diabetes incidence. So this study on the face looked, a negative study. But when they looked at the data, the deficiency of vitamin D was present only in 22% of the people with pre-diabetes who were recruited in the study. So the post-hoc analysis was done. It showed that people who had severe deficiency, the levels of less than 12 nanogram per ml, there was 62% reduction in the development of diabetes. And those who maintained levels of more than 50 nanograms per ml showed a 76% reduction in the risk of getting diabetes as compared to those who had levels less than 30. So it showed that maintaining optimal serum vitamin D levels may confer substantial protective benefits in terms of reducing the risk of diabetes. Then we had VITAL trial, which again was a randomized controlled study involving 25,000 US adults and who were given daily vitamin D supplementation of 2,000 units. The follow-up did not show any significant reduction in the vitamin D of diabetes or metabolic syndrome in general, but the post-hoc analysis again showed potential benefits among people who were vitamin D deficient at the time of recruitment. So there was a significant trend towards benefit in terms of reducing the cardiovascular risk and metabolic syndrome. Then we have data from enhanced study looking at the mortality outcomes in diabetes. and this data was based between 2001 and 2014, data of the individuals assessed in US. Over 8.7 years of mean follow-up period, there was significant reduction in the all-cause mortality, and the people who had vitamin D levels of more than 75 nanograms per 75 nanomoles per liter, there was 42% lower risk in mortality as compared to those who had levels less than 50 or less than 25. Then we have very large Danish cohort study. This was a population-based cohort study in Denmark, assessed the vitamin D status and risk of type 2 diabetes in 2022 patients, and showed again, significant benefit in terms of reducing the risk of, diabetes or overall risk in people who had vitamin insufficiency. Then we have number of meta-analysis and observational data, again showing benefits of vitamin D. Now, if you look at the global perspective, we have a large population of 1 billion worldwide, and despite abundant sunshine, we have high prevalence of vitamin D deficiency. I think my timer was set wrongly because the time was 18 minutes. I think we have only 15 or something. Change? Okay. No, I don't want to talk as long. So we have large population, but in India we have widely prevalent, vitamin D deficiency because of multiple factors. We have darker skin pigmentation, air pollution, predominantly vegetarian diet, limited food fortification, so many things. And till recently, India lacked population-specific consensus-based guidelines on screening, supplementation, and target levels. And there are a number of guidelines which have come from various, international agencies which are focused on vitamin D deficiency, prevalence, sunlight exposure, dietary practices, and so on. So, Endocrine Society came up with the guidelines in 2024, but it had a very focused approach, limiting the recommendations to disease prevention, generally healthy individuals, and moved away from defining deficiency thresholds or discourage, routine screening. Now, in India, we did not have any guidelines. 2024 Endocrine Society, recommendations state that there is no recommendation for screening. There is no recommendation for less than 1 year of age. Between 1 to 18 years, it recommends supplementation with average dose of 1200 international units per day. Between 19 to 69 years, average dose supplementation of 600 units per day. After 70 to 75 years, about 800 units per day. And after 75, it recommends the supplementation on an average of 900 units per day because of the increased risk of mortality and fractures. In pregnancy, there is a higher dose recommendation for supplementation, approximately 2,500 units per day because of the potential to lower the risk of preeclampsia, IUD, premature deaths, and so on. And adults with high risk of diabetes, the average supplementation recommended is 3,500 units per day. Institute of Medicine again, came up with the guidelines in 2015, recommending minimal dosing on bone health on population averages, and very little emphasis on extraskeletal benefits. Mexican consensus guidelines again, had a different approach, and this is the comparison. But the important thing you will realize in this, table is that all guidelines agreed that deficiency is to be defined when the levels are less than 20 nanograms per ml. Insufficiency is defined either about 20, or some guidelines, put a category of insufficiency between 20 to 30 and sufficiency about 30 nanograms per ml. Because of these reasons, we thought there was a need for India-specific guidelines because we have highly prevalent vitamin D deficiency, no standard guidelines, no specific recommendations for vitamin D supplementations, and inconsistencies for the cutoff values. And therefore, a consensus was required. And for this, 41 endocrinologists from across the country got together, developed a guideline using Delphi method, and this was published in the IGEM, which is Indian Journal of Endocrinology and Metabolism, this year only. This guideline gives a standardized definition of severe deficiency, deficiency, insufficiency, and sufficiency, and also gives clear guidelines for screening strategies, population-specific supplementations, and dosing in special population. So target vitamin D levels for Indian settings are also defined. Now, I am showing you the comparative chart here. So the purpose of guidelines in Indian setting was to address widespread vitamin D deficiency in Indian population, to guide diagnosis, supplementation, and targets. The sufficiency threshold is kept between 40 to 60 nanograms per liter and not less than 20. And deficiency is defined less than 20 nanograms per liter. So this is because we have lower absorption of calcium in Indian population and we need higher levels of vitamin D to optimize the intestinal absorption of calcium. Also, if you look at the PTH level studies, the studies in Indian adults show that PTH suppression plateaus at 40 nanograms per ml, not at 20. And so higher threshold, we need higher levels of vitamin D. Then if you look at the environmental and lifestyle limitations, we have darker skin. People are, avoiding sunlight because of the high heat or tropical weather, and sunlight alone appears to be insufficient. So it is recommended that we should screen high-risk groups like elderly, pregnant, obese, chronic illnesses, and general target group for supplementation should be general population and all risk groups. And the recommended daily dose for adults is about 2000 international units per day to maintain a sufficiency level of 40 to 60 nanograms per ml. Universal screening is not recommended because of the cost. Then high risk conditions which need routine vitamin D supplementation are recommended to be conditions such as cerebral palsy, neuromuscular disorders, chronic kidney disease, chronic liver disease, malabsorption syndromes, people who are on drugs like glucocorticoids, anti-epileptic drugs, ketoconazole, endocrine diseases such as hyperparathyroidism, and people who have skin diseases. If you look at the varied guidelines, Endocrine Society defined the upper safe limit for 10,000 units per day as supplementation level. In Indian guidelines, we don't have any specification. We have age-specific recommendations to maintain the serum levels in the same range, and loading doses recommended, which is not recommended in most of the guidelines. So for for the children, 0 to 6 months recommendation is for 400 units per day. 6 to 12 months, the recommendation is 400 to 600 units supplementation per day. Less than 3 years, 600 units. Up to 10 years, up to 1000 units per day. Now, this is a graph which shows recommendation for supplementation in adults. So people who don't have any signs or symptoms and have vitamin D sufficiency, 60,000 units a month is sufficient for maintenance. People who have vitamin D insufficiency and are symptomatic, they may not have any signs. We have to focus on, of course, dietary intake, good dietary intake, and supplementation of vitamin D, rich foods, and exposure to sunlight in all the conditions. But if the levels are low, then 60,000 units once a week for 8 weeks is recommended in people who have insufficient levels. That is between 40 to 20. And once they have been given this, you again see the response. If the response is satisfactory, they are recommended 60,000 units month to month. People who have deficiency, recommendation for loading doses for 12 months, followed by, again, if there is a satisfactory response, once a month, 60,000 units. Children 3 years and above with confirmed vitamin D deficiency, 6 months loading dose. Adolescents, again, 6 months loading dose. So in Indian consensus, we have focus on extraskeletal benefits, pregnancy, and other health conditions. The base for the guidelines or recommendations is observational expert consensus and Indian prevalence data, and we think supplementation is needed for all these people. So for elderly, the recommendation is 1 lakh units every 90 days, every 3 months, or 4,000 units per day supplementation. In pregnancy and lactation, we have to maintain level between 30 to 50 nanograms per ml, and the recommendation is 2,000 units per day for on daily basis throughout the pregnancy. People who are on drugs which can lower vitamin D, recommendation is 6,000 to 10,000, and then for immunocompromised and other conditions we have separate recommendations. So general recommendation for supplementation is about 2,000 units, and the target is 40 to 60 nanograms per ml. So we have in nutshell high prevalence of vitamin D deficiency, and we did not have guidelines. So we have now clinical practice recommendations recommending that we should target a level of 40 to 60 nanograms per ml, and we should have supplementation for general population as well as for the high risk groups. With that, I conclude my presentation. Thank you for patient hearing. Thank you.